Public health is the special source that is all around us, that is keeping us healthy on a day-to-day basis.
Essentially, it's about stopping bad things from happening, if you want to put it in its simplest possible terms.
Public health is prevention over cure.
Improving population health equitably.
Welcome to Public Health Is, a podcast brought to you by the Public Health Association of Australia. I'm Dr. Stephen Owen, and today we're bringing you a conversation about the Australian Centre for Disease Control with the CDC's Director General, Professor Zoe Wainer, and the PHAA's CEO, Adjunct Professor Terry Slevin.
Zoe, thanks for joining us on one of the very first podcasts on Public Health Is. Congratulations and welcome to the role of Director General. I know you've already been in the chair for a few months. You know very well it's very public. Public Health Association of Australia was very active amongst many champions for the establishment of the CDC. So we've made public in very many occasions our enthusiasm for the establishment of the agency and are here to support and encourage its success. So we're here as fellow travellers. We think the CDC is a vitally important agency, but you're the inaugural Director General. What excites you and what daunts you about the job?
Everything excites me about the job. I genuinely think it's probably one of the best jobs in healthcare. I think it's remarkable legislation that supports the organisation. The other thing that excites me is the extraordinary response we're getting from external stakeholders. Literally globally, people are excited about the CDC, the Australian CDC, when we were at the World Health Assembly. I felt like I had the busiest diary in town because every country, every CDC really wanted to connect with Australia to understand what the new CDC was, what it does, and of course how we can partner both regionally and globally. I think we are seeing increasing and will continue to see increasing public health risks globally and nationally. We have a bit of a joke in the CDC that we haven't had time to do any tabletop exercises because we've been actually in response non-stop. If you think about the number of outbreaks that we've had both locally but also regionally and globally, it is relentless. And so it feels like an incredible privilege, Terry, to be in the role, working with extraordinary people who work in the CDC, but also, as I said, just the genuine enthusiasm and support for the organisation, of course, from organisations like your own, but very broadly to the research industry saying, how do we support and help the CDC? It really has been an incredible welcome. But of course, with that incredible welcome goes great expectation.
Yeah.
And so what daunts me a little bit is some of the expectation. There is, and I've talked before about the importance of understanding the legislation. It really does step out our functions very clearly. And there is an expectation that we're sort of going to be able to fix everything in public health now. We are a very young organisation. We started on the 1st of January. I started in March. And it takes time for an organisation that's managing the kind of complexity that the CDC is to be able to hit full speed. Having said that, we're doing a great job, I think, in terms of surveillance and response and supporting the department and the Chief Medical Officer in response as well. But we have a lot of growing to do.
Great. Now, there's one we need to knock off early, and the context is we have a Prime Minister who's my vintage. He's obviously a keen music fan and a child of the 70s and 80s, and I've always thought it tickles his fancy to create an ACDC, but that's not a label we're allowed to use. Is that correct?
Correct. I can't use ACDC. Somebody actually seems to have beaten us to it. And also, of course, there's the African CDC. There are other ACDCs as well that we need to be respectful of. But no, it is the Australian CDC.
Excellent. All right. You've already mentioned,
You can potentially say the Highway to Health. So that
well,
would be previously.
If these blokes don't put some music stings on this, I'll be very disappointed. You already mentioned, you kind of dropped in the deep end, and since the Australian CDC, I got it right, has started, obviously, just in the first even 3 or 4 months, we've seen a hantavirus, Ebola, encephalitis, diphtheria, and now bird flu.
Don't forget Marburg.
And Marburg as well. And all of these are kind of landing in the top stories in our news feeds. So before you've had a chance to establish all of the various infrastructure, how are you wrestling with those challenges? What have they taught you? And how do you anticipate them unfolding both as health issues and then how you deal with it as an agency?
I think the processes have actually worked really well. Obviously, as I said, we're a new organisation. There are functions that used to sit in the department. There's been work between the department and the CDC to understand those roles and responsibilities, and that's still evolving, very much in a partnership approach. But I think we're seeing that the systems are working. So we had a polio wastewater detection in Western Australia, and that was a really interesting process because that doesn't mean that we have polio necessarily. It was vaccine derived. But what it does tell us is the surveillance systems are working. We picked it up. It allowed us to increase surveillance in the area. It allowed us to educate clinicians in the area about what to look for. Of course, some of these diseases I was taught in medical school we'd never see.
Yep.
Syphilis, diphtheria, polio, and yet they're re-emerging at pace.
Measles.
Measles is another one, absolutely. And so I think whilst we absolutely always have areas to improve and we strive to be a learning organisation that is constantly reviewing and examining the response, working closely with the department to say what's working and what's not working, I think in the early days that the community can feel reassured because we are seeing the CDC able to support the response, to have the international horizon scanning, to have those international networks, for example, with hantavirus, so that we could ensure that Australians will return safely to Australia after that outbreak. So whilst absolutely there are always opportunities to improve and learn, I think we're seeing the proof of the value of the CDC through those examples.
Now, you've gone to a question I was going to ask later, but it kind of brings it to the fore now, and that is you're a government agency and you're landing into an environment where everybody else is doing this stuff. Okay, so you're the new kid on the block. So the nature of the relationship you have with other agencies at a Commonwealth level, states and territories, people outside of the government ecosystem, that's all central to just the things you've just been talking about. So how is that evolving? How are you navigating the creation of those connections, rules that guide them, that machinery?
States and territories are absolutely vital to the success of any public health initiatives in this country. They do the on-the-ground response, working closely with them and understanding how the CDC can add value to the states and territories is something really central to our DNA that we're working very hard to explore with them about what is the value add that the CDC can bring. We absolutely do not seek to replicate, duplicate, or replace any of the current infrastructure. We are an addition to and a support mechanism. The Department of Health, of course, does a lot of the responding, but we are there to provide the intelligence, the horizon scanning, the evidence gathering. And of course, we have the AHPC, which is chaired by the Chief Medical Officer. The CDC supports 5 of the 7 subcommittees of AHPC as well. So, and I sit as an ex officio member of AHPC. So that's another forum where we ensure that there's good integration in how we respond to public health threats and challenges. We are independent, and that means independent of the department. As you've pointed out, we are a government organisation, so I report directly through to Minister Butler. But that independence is actually really central to our legislation. As you know, through the legislation, we have the authority to publish public health information and advice that is final and settled without government approval. And that's really important, I think, in terms of creating that sense of trust and confidence with states and territories, but really importantly, more broadly with the community, so that they know the public health advice that comes out of the CDC is the pure public health advice that we have gathered as a consequence of our horizon scanning and intelligence.
Yeah. So you mentioned CDC. There's an extent to which the punter out there, as I look out your window, I can see people's houses. They might have heard of the American CDC and have a bit of a sense as to what they're about. So you've got a leg up, if you like, in terms of that perception. But how do you see that playing out in relation to the puntocracy, the people who ultimately you're there to serve, the nature of your relationship with them, how you reach them, what their expectations of you are? How does that relationship, for want of a better term, unfold?
I did have a member of the public say that they'd been looking at a website for a decade and it had been fantastic. Just gently referred that perhaps that was not the CDC, but to your point, there is a community awareness.
Yeah.
Look, I think we aim to play a very central role. So one of the functions that we think we can do to add to what is already a mature public health system is to build that trust and confidence with community, to be seen as the reliable go-to place for information. So you see bird flu in the press, you think, gosh, I wonder what the CDC has to say. That's where we want to get to. We want to be seen as the clear broker of that really important information and looking at, again, we're very young, so we're still working on this, but what are the innovative ways that we can engage with community? Again, also that comes back to states and territories. They often know their communities far better than we can possibly ever do. But as we're sort of evolving those relationships, I think the CDC has an opportunity to play a role in what I refer to as kind of like the communication spine. We can really bring together and synthesize the evidence and the information in plain language, and then the states and territories are in a position to be able to use that to build their own context and information.
So in as much as you need to build trust with the people in the houses that I can see from here, you also need to build that trust and relationship with the people who work in states and territories and even probably local government area level as well.
Yeah, but you also touched on other Commonwealth departments, and I think we're seeing a classic example play out at the moment with avian influenza. We're working very closely with DAF, Department of Agriculture, Fisheries and Forestry, who obviously are the primary government responder in this situation because
Mm.
it is in seabirds. But it's absolutely important that we're ready to go if human health is at all impacted. And we're providing that ongoing advice into the regular forums at the moment, which have multiple state, Commonwealth government agencies present.
Yes, I remember seeing, I think it was the first interview I saw at least, of the chief vet at DAF, Department of Agriculture and Forestry, um, that talked about, well, she actually referenced communications with the CDC and how that was being connected. So clearly that link had been established very efficiently at the start. So that was really encouraging.
The CDC has a dedicated One Health team, which is really looking at the interaction, of course, between environment, animals, and human health. And I think we're seeing that play out quite significantly. We have avian influenza, we had hantavirus, some of the origins of Ebola are in that same space. So we are regularly talking to Dr. Cookson. We actually have a group that meets, which is myself, the Chief Medical Officer, and the Chief Vet, to make sure that we are across and understanding the challenges and ensuring that Australia is well protected.
Now, there's an issue that I wanted to explore, and that is boundaries. What's your patch and what's not? And it was very actively discussed as the legislation evolved, what to be included in what was counted as public health matters. And it landed on 8 of them. I'm not going to quiz you as to list the 8. But I'm interested for you to talk about how you navigate that given the breadth that's there and how you conceptualise that turf. First conceptualising and then operationalising. So how are you wrestling with the breadth and nature of your patch?
Hopefully well, but I would suspect it's for others to judge from the outside. It is a broad area. As you're very aware, the legislation is quite clear on what our functions are. And in the early days, that's communicable diseases and environmental health. And environmental health includes One Health, antimicrobial resistance, pollutions like PFAS and microplastics, and the impacts of climate change and heat in particular. As I said at the beginning, our ethos is really clear. We don't seek to duplicate, replicate, or compete with anybody who's in the area. Our job is to add value in all of those areas. So we very much have a culture in the CDC of seeking to understand the importance of other players in that ecosystem so that we can be seen as a partner rather than having to kind of defend or protect turf. We absolutely don't view our area and our work that way. The CDC really was set up because there was, as the PHAA has identified and others for a long time, there was this gap in terms of independent public health advice, intelligence monitoring and surveillance. And if we do kind of trip over each other, because it is very early days, as you point out, then that's a conversation. And it's actually a conversation that can deepen trust. And that's the approach that we take.
Okay, so moving on to that issue of patch, and you've articulated the priorities, and you're right, it's crystal clear in the legislation. But at the time when the
It's not that hard to read either, is it?
No, and you and I both promote the notion that people should read the legislation, and I'll continue to do that, and I'm sure you will too. But within it, disease prevention is clearly one of the 8 public health matters. And at the time, then in opposition, the leader, Anthony Albanese, now Prime Minister, articulated the intention to establish the CDC at the Press Club address in 2020. He also talked about the role of CDC playing a role in chronic disease prevention. A lot of people in my world, my membership, me personally, were advocating for that to be a part of the responsibility of the CDC from the outset. But it was that stepped approach that became ultimately the decision to proceed. But there will be lots of people wondering, okay, how do you see that? How do you see that playing out? We know there's built into the legislation a review period. So what's your take of how that might actually function?
At this point in time, our focus is, as we've just discussed, communicable diseases and environmental health. We know under every single one of those areas, determinants have a huge impact. Equity has a huge impact. So again, at the heart of the CDC is equity. Who are the populations who are most impacted? And if you have one or more multiple chronic diseases and you have an infectious disease over the top of it, you will have a worse outcome. And we also know those social determinants of health mean that equity means that we have areas that are really challenged priority populations that we absolutely have to focus on. So we don't see it as a tomorrow issue. Appreciate that the work that happens in non-communicable diseases, population health and promotion and prevention happens elsewhere at the moment. And we're very supportive of that work. But we also recognise it's almost, at the risk of being controversial, that it's almost a spectrum and not quite as dichotomous as we would like to make it, communicable and non-communicable diseases. It's interesting talking to CDCs around the world. Some don't think that you should include non-communicable diseases because they say the pace is so different between communicable and non-communicable that the culture becomes very gritty and difficult in an organisation. Finland has a very different take on that. So they have everything, including the social determinants of health, in
Right.
their
Okay.
National Public Health Institute. And if you talk to their deputy director, which I had the opportunity to do so in Kuala Lumpur at the Global Health Security Conference, he says he thinks that's a false dichotomy. It's a continuum, and to try to split them out doesn't make sense. So there are quite a wide and diverse range of views about what works and what doesn't work in terms of bringing that in. For us, I think it's good in the early days that we're really focused on communicable diseases and environmental health because we're a new agency. The message I'm getting loud and clear from government is we want you to go slow as much as one can when you have multiple outbreaks, get the foundations really solid for the CDC. So it's a deeply trusted organisation by our communities and our states and territories. And then let's consider whether or not broadening the remit would be to the benefit of the Australian community.
And that trust theme keeps coming up. You mentioned it a couple of times, and it's expressly stated in the legislation as well. And we all know this is a challenging environment off the back of COVID-19 and the range of things that have evolved since then. An observation, you can argue the extent to which it's true, is a reduction of trust in government broadly, public health particularly, and in that environment and the outbreak, if you like, of misinformation, commercially driven information, however it's conceptualized, even ideological. Tough environment to build trust. What's the core, what's the key way you tackle that enormous challenge? How do you win?
So I don't think there's one key way. I think there are multiple ways that we have to tackle this and understanding the drivers of mis and disinformation. I was listening to epidemiologist and communications expert who was saying, we know when you come out with a new policy or an idea, you will get criticised from an economic perspective, from a political perspective, from an ideological perspective, and from a financial perspective. So we should be much more prepared in that pre-bunking space so that we are ready for that criticism that will come, so that we deeply understand it. But Terry, I think another thing for me is I've heard a lot about building trust is about transparency and evidence. And I think if it was that simple, we wouldn't have the problem. I think we actually genuinely need to listen to areas of concern. We need to listen to the community because they're not raising concerns or trust because they want to be difficult. They're doing it because they have genuine questions and concerns. So it's our job to actually listen deeply to what those concerns might be about. Now, we're not naive. We know there are commercial determinants that are driving that seek to undermine the trust. And that is absolutely an area that we need to stay focused on. But in taking into our response, really, how do we understand to build that trust? We need to be aware of those drivers. I think my other observation is Professor Paul Kelly articulated this concept for me. I had observed the process but didn't know its name, which is hindsight bias. So hindsight bias is effectively a response that people can have to trauma where they want to retell the history to minimise the impact that it had. I even have friends who've said to me, oh, well, COVID was a bit of an over-response, wasn't it, Zoe? And I remind them of the vision that was coming out internationally of healthcare workers dying in the corridors of hospitals, of running out of mortuary bags, of needing to bring refrigeration trucks into Central Park because they'd run out of morgues, of mass burials. This happened. And I know there's a lot of debate about Australia's response to COVID, and I don't want to enter into that space, but it didn't happen here. And so I think working with community to remind them, of course, it was an awful event. You can understand why people want to minimise that trauma, but it is on organisations such as my own to understand that, to seek to deeply understand that, and then how we can work with communities to ensure that they are protected in the way we know public health can do so without that loss of trust or confidence.
When you do something to prevent bad things from happening, people only ever remember what you did. They don't acknowledge or even process the bad thing that didn't happen. So most people's experience of vaccination is, a jab in the arm and maybe a sore arm. What they don't conceptualize is the disease they didn't get.
Yeah.
So prevention becomes.
Or even in herd immunity, that they may not have had the vaccination, but they're benefiting from others having the vaccination as well.
You touched earlier on the issue of independence, and it was a really constant theme through the discussion, all in the lead up to the CDC. It's articulated again in the legislation. Ultimately, you're the person who decides. You make the call. Do I do this? And draw upon that independence card. What are the things that guide your decision in doing that?
It's always what's the best outcome for the community. Always. That's what's central. And that's genuinely the support we have as an organisation. There is genuine political commitment to that independence. And I think it comes through the recognition and the knowledge actual or otherwise, that there may have been political interference during COVID of public health information. And so we have incredibly bold legislation which empowers us to publish that information. But importantly, one of the elements of that independence is that government might make a different decision. And they'll make a different decision based on a whole variety of factors that I don't need to take into account when I'm thinking about the public health advice, purely the public health advice. Education, economics, all of these are really important factors that government has to decide. And the advice and information we provide is one of those factors. And we will do so publicly so that the community understands what the public health advice is. And then it's up to government to explain that.
And conceptually, that is absolutely the way it should play out. And a really fascinating game will be when the rubber hits the road. And it's only ever going to be tested in the real world when it has to be tested in the real world. For what it's worth, I'm sure there'll be a lot of people out to support exactly the prosecution of that power as and when it needs to happen.
But it's a power that one only uses with great caution and great consideration. I have an organisation that is full of extraordinary technical experts, and I would never make a decision like that without working incredibly closely with those. As you know, in the legislation, there's also an advisory council that's in the process of being set up, and that will have a range of experts on it who would also provide advice to me at that point in time.
I want to move on to the role of the punters out there, the wider community. What role can people around Australia play with regard to the CDC in terms of articulating what they expect, in terms of having input, and what role do we invite everybody in this country to play when it comes to the evolution of this agency?
Because community is at the heart. The protection of Australians is at the heart of the CDC. But if they don't feel protected, then are we doing our job? We are, as I've articulated previously, early in our governance days, but we are setting up the mechanisms and processes of how we best engage with communities, how we best engage with, as you had said, the punter down the street who may or may not have heard about the CDC. I mean, this is just a bit of an obvious public health plug, but what Australians can do is get vaccinated. And we'll keep saying that because that's an incredibly powerful tool for reducing severity of disease. We know every single vaccine preventable disease that we can give a vaccine for, you see a significant drop in the rates of the disease. I might get the figures a bit wrong, but I think it's about 153 million children whose lives have been saved since 2000. Through vaccination. And I absolutely don't want to in any way undermine what can be terrible experiences from vaccinations. Every medication that we prescribe has potential side effects, but that's why we have really important systems in Australia that monitor the quality and safety of vaccinations, both before market but also during.
And that's an issue about trust as well. During that, we stick to the science that says on the full balance of scientific evidence and probability, there are a net benefit of this. Along with it goes a risk, and here's how we best articulate and quantify that risk.
And I think we need to be honest with community about the risk. And I think we saw some challenges, not that people were not being honest during COVID, but the evidence was evolving so quickly. And we do have to be comfortable saying sometimes we don't know the answers. We're working really hard to understand it, but we're not infallible. Medicine is not infallible. We know that. Healthcare is not infallible. So we need to be honest with our community about when we do and when we don't know. And that's part of our role as well.
That's the authenticity magic sauce to some extent.
Yeah.
Zoe, we could talk forever, but we've got to wind this up somewhere. So I'm going to invite you just to think about and talk to us about what you think a job well done looks like. Tell us what you see as your KPIs. I mean, we've got legislation and we'll have ministerial opinions and punters will have views and people in my world, my members and others will have views. What do you see as success for your role into the CDC?
One of the metrics, and it's early days for me in establishing how we do this best, but I was at a dinner the other night that had an important part of the medical sector present, and they said to me, "You're small. How do we use our networks to enable you to do the kind of national, regional, global work that a CDC needs to do?" And I don't yet know the answer to that question. And we get those offers of support a lot, and so that's something the team and I are thinking about. How do you act on that? What is the so what? What could we do together in partnership? I think people very much are hearing that we're dedicated to partnership, collaboration, connection. But I think what that means is still something we're working out. And I think that is one of my KPIs. And it's not just in Australia. We have a regional responsibility, both as an active regional member, but also from a leadership perspective, from a supports perspective, from a capability perspective as well. You and I were talking about equity. And I think some of the challenges we see in our regional neighbours, particularly when it comes to climate change, have deep equity issues in them. They're really challenged by just day-to-day impacts of climate change with sea level rise, with the changes in the climate. impacting health. Dr. Sire, who's the WHO Western Pacific Region Regional Director, ironically, he and I actually did cardiac surgery together in Tonga in 2009, but he's really strong on this, that his people are being impacted now. This is not a tomorrow issue. I think the CDC has a really important role to play in partnership in the region as well. So that's another KPI for me. I'm also very keen that we have good global networks. We're exploring currently how we might harmonise some of the research protocols for syndromic research so that when you have an outbreak, you can instantly start the research to understand the disease, the diagnostics, the vaccinations and the medications. That will be much more powerful if we can harmonise that regionally and even potentially internationally, because it makes those research collaborations have a lot more oomph when it comes to the denominator, if that makes sense. So that's another really important KPI. I think some of the other metrics for me we're achieving. So I think we're responding well. As you and I have outlined, there's been a lot of diseases that we've had in the first 6 months. And I think hantavirus, the polio wastewater detection, avian influenza, these are all demonstrations that we're doing surveillance well, we're responding effectively, that people are still safe, the community is safe despite these threats that are coming. So for me, you asked me in the first question, what daunts me? What daunts me is the unknown. I think we have quite a lot of known unknowns. We understand the likely syndromic situations that will happen if it's viral hemorrhagic fever, if it's a respiratory outbreak. We have a lot of knowledge already around how we manage that. But I, like many other public health people, are worried about disease X. What happens when there's a mutation we haven't anticipated, and those measures that we have in place now are no longer effective. So another KPI is how agile are we? How quickly can we pivot? And as I said, those international relationships are really important in that moment as well. We had an all-staff day and we asked this question, what did success look like? And the one that stuck with me that I love the most is you can't get a job at the CDC because everybody loves working there and no one's going to leave. So thinking about the health and well-being, the passion of our people, the culture that we build as an organisation that's agile, innovative and fun, particularly because we know the challenges are serious and that the trust between the teams is just as important as the trust with community as well. It will strengthen our ability to respond. And that's not just internally, that's also good partnerships with the Department of Health, good partnerships with the states and territories. But at the heart of any organisation like this is the people.
Zoe, I suspect we could talk on a lot more as we've been talking. I've been thinking about a dozen more questions, relationship with the research community and your role there, a whole bunch of other stuff. But I think what we might do is simply say, can we consider this part one?
Absolutely. Terry, we would love to consider this part one and have regular catch-ups.
That's great. Zoe, thanks very much.
Thanks, Terry.
Good on you.
Thanks for listening to Public Health Is, a podcast from the Public Health Association of Australia. It's created on the unceded lands of the Ngunnawal and Ngambri people in Canberra, Australia. Learn more about the association and the benefits of membership at phaa.net.au.
Public health is the special sauce.
Stopping bad things from happening.
Public health is the special sauce.
Stopping bad things from happening.